Assalamu alaikum. My seminar today is about the salivary gland disease. First of all, we're going to talk about the introduction and then salivary gland aplasia, mucocele, ranula, sialolithiasis, necrotizing, sialometaplasia, and allergic sialodentitis. The salivary glands are tubulo-acinar exocrine organ that responsible for production and secretion of the saliva, which consists of various organic and inorganic substances that help in mastication, deglutition, and digestion of food. We have a major and a minor salivary gland. Like in this picture, gland. First, we have the parotid salivary gland, which is a serosal and open by a single duct, which is the Stenson duct. And we have the submandible, which is a mix between serosal and mucous cell and open into a single duct, which is the Wharton duct. And we have the sublingual gland, which is a mucous cell. The minor salivary gland distributes into different parts of the mouth, like the labial, buccal, lingual, palatal, alveolar mucosa, and the floor of the mouth. The salivary gland aplasia, it's a rare developmental anomaly that can affect one or more of the major salivary glands. The clinical feature report more frequent in men than women by 2-to-1 ratio. The most symptom is xerostomia, a tongue appear leathery, and it's more susceptible to dental caries and erosion. The treatment is by sialogag medications such as pilocarpine or simivillin, and it may be increase the salivary production, and the salivary flow is stimulated by the use of sugarless gum and sour candy. Like in this picture, we have the leathery tongue and susceptible to caries and erosion. Mucocele, it is a swelling that caused by accumulation of the saliva at the site of the traumatized or obstructed minor salivary gland duct. It can be extravasation or retention type. The extravasation, it is the most common type, which is a result from trauma to the minor salivary gland. And the retention type, it's caused by obstruction of the minor salivary gland duct, and this blockage of the salivary flow results in accumulation of the saliva. The clinical presentation: painless and smooth surface swelling. The superficial lesion is characterized by blue in color, and the deep lesion, it's more diffuse and covered by a normal appearing mucosa without a blue color. Although the developmental bluish lesion after trauma, it's high risk of differential diagnosis like salivary gland neoplasia and soft tissue neoplasm and vascular malformation and vascular bullous disease. The treatment is conventional definitive surgical treatment of mucocele, involves removal of the entire lesion with the feeding salivary gland and duct, and incomplete removable will prevent a recurrence. Like in this picture, we have a mucocele superficial lesion, blue in color. Ranula, it's a mucocele but occur in the floor of the mouth and arise from the sublingual gland, and it's much bigger than the mucocele. The positive cause is mechanical trauma to its ductal of ravenous, result in extravasation of the saliva and obstructed of the duct. The ranula is usually appear painless, blue dome shape, and swelling in the floor of the mouth, but deeper lesion it's appear normal in color. The treatment of ranula it consists of remove the entire lesion. Hyalolithiasis it's a calcified organic mass that form within the secretory system of the major salivary gland. The etiological feature we have three groups. First, factor favoring saliva retention like irregularities in the ductal system, local inflammation, dehydration, medications such as anticholinergic and diuretase. Second, the saliva composition like calcium saturation. And the third, we have the bacterial infection. A clinical feature of the hyalolithiasis, it's happened more frequent submucosal submandibular gland like it happened more frequent in the submandibular gland from 80 to 90% because first tortoise course of Wharton duct, second high calcium and phosphate level of the secretory component, and third thickener mucoid secretion of this gland may be responsible for its secretory tendency from salivary calculi. The patient with the hyalolithiasis more common presents with a history of acute chalky pain and intermediate swelling that affecting the major salivary gland during a meal. This is the hyalolithiasis in the Wharton duct orifice of the Wharton duct, and this the X-ray of the calculi. The treatment during the acute phase of the hyalolithiasis therapy, it's primarily a suppurative. Standard treatment during this phase often involve the use of the analgesic and hydration and an antibiotic until antiviral is necessary. Using of the cyanogax drugs and drug or substances that increase the flow of the saliva, like chewing gum or medication like glucarbine with simivilin. Massage and heat application to the affected area may be also beneficial, and the stone which is near to the orifice can make milking to the gland. Necrotizing hyalometaplasia, it's a benign self-limiting reactive inflammatory disorder of the salivary tissue. Clinically and histologically it resembles a malignancy. The etiology is unknown. The clinical presentation, it's more commonly presents as painful, rapidly progressive swelling of the hard palate with ulceration from the center and erythema in the peripheral. The pain is described as sharp pain and numbness, and anesthesia it's the early sign. The lesion is occur predominantly in the palate, and it can occur in the lip and the retromolar and the buccal mucosa, tonsils, and the tongue and the nasal cavity, trachea, and the maxillary sinus. Here we have the necrotizing hyalometaplasia in the early stage, and here we have it on the latest stage. A number of potential precipitating factors that has been suggested, including traumatic injury, dental injection, and an offsetting denture, smoking, adjacent tumor, and previous surgery. The treatment is self-limiting and typically removed from 3 to 12 weeks. The cheilitis granulitis is a chronic inflammatory disorder that's affecting the major salivary glands and their duct, which is a thickening of mucosal secretion from the dilated duct opening, characterized by superficial ulceration, painless and the swelling and the exudate appear in the ductal opening. The etiology is unknown, but it is suggests that autosomal demand hereditary disease, and the external factor it is the UV light, and it's more frequent in fair skin adult and albino patients. The treatment is just eliminating the precipitating factor and use lip balm and sun cream for those patients who is more exposure to the sunlight. Allergic sialodentitis, the enlargement of the salivary gland has been associated with exposure to various pharmaceutical agents and allergens like heavy metal and iron compounds. And thank you.